Okay, buddies, let's talk about Lyme disease now. This patient has symptoms associated with long-standing Lyme disease. So, what is Lyme disease? Lyme disease is caused by spirochete, Borrelia burgdorferi, which is transmitted by the bite of an exodes tick. Lyme disease is endemic in the northeastern United States and northern Europe. It's in northeastern United States and northern Europe. Like syphilis, another spirochetal infection, Lyme disease progresses through a predictable series of phases or a localized phases. It occurs days to weeks following the exposure. Patients experience flu-like symptoms and a characteristic cutaneous eruption. Okay, so erythema migraines occur. So erythema chronicum migraine occurs in the localized state. Then in the early disseminated phase, weeks or months later, they may involve central nervous system causing facial palsy, cardiac involvement, that is AV nodal block, and in late Lyme disease, it occurs months to years post-exposure, and it's rare given the frequency with which patients receive antibiotics for other indications. Patients may experience asymmetric arthritis, most involving single knee joint, as in this patient. Single knee joint. So knee joint can be involved, and or subacute encephalopathy with decreased memory, somnolence, and mood changes can also occur. So subacute encephalopathy can occur, causing decreased memory, somnolence, and mood changes. Lyme disease is easily treated with doxycycline or penicillin type antibiotics. Example, ceftriaxone. So this patient does not appear to have noted extracellular noted ECM, so erythema migraines, for which he would have likely have received Dr. Sagan. However, treatment with ceftriaxone, when he developed the facial palsy, possible manifestation of early disseminated Lyme disease, would have prevented progression to late Lyme disease. So this is erythema migraines. Allopurinol completely inhibits xanthan oxidase, suppressing uric acid synthesis. This drug is used to treat gout and prevent uric acid kidney stones and tumor lysis syndrome. So allopurinol inhibits xanthan oxidase. Therefore, xanthan oxidase is not present. Therefore, uric acid formation is impaired. So it is used to treat gout and prevent uric acid, kidney stones, and tumor lysis syndrome as well. Lamivudine is a nucleoside reverse transcriptase inhibitor used for SIV treatment. So lamivudine is a nucleoside reverse transcriptase inhibitor. So NRTI used for SIV treatment. A Borrelia burgdorferi vaccine, now discontinued due to low sales, contains a recombinant outer surface protein from this bacteria, not live organism. So live organism is not present. However, recombinant outer surface protein is present from this bacteria. So mefloquine is the next point. Next is a drug, antimalarial drug used in prevention treatment of plasmodium falciparum. So mefloquine is used for plasmodium falciparum, and metronidazole is effective against anaerobic bacteria, Clostridium difficile, bacteroides, and parasites. Intermediate, so Lytica, Giardia, and Trichomonas personalis. Now, let's talk about hemochromatosis. So let's talk about hemochromatosis from this video. Hemochromatosis. Okay. So let's watch the video first. There will not be any sound here.
Hemochromatosis is a metabolic disorder where the body absorbs too much iron from the food you eat. This accumulation of iron leads to elevated iron in the blood and poisoning of the tissues in the liver, pancreas, heart, pituitary gland, joints, and skin. The root chromat actually refers to colon, the cell that activates the
So, clinical manifestations of hereditary hemochromatosis is skin hyperpigmentation occurs, muscular arthritis, particularly second and third MCP joints. So, metacarpal pharyngeal joints, second and third metacarpal pharyngeal joints are involved, and chondrocalcinosis, so calcium deposition in the cartilages as well. And the every liver enzyme, hepatomegaly, serious inhibitors at HCC, and diabetes, hypopituitarism, secondary hypogonadism, hypothyroidism can also occur, cardiomyopathy, conductive abnormalities can also occur. This patient has chronic arthritis. If a patient has chronic arthritis, okay, fatigue, and sexual dysfunction, which together suggest hereditary hemochromatosis. So, chronic arthritis, if joint pain occurs, fatigue occurs, and sexual dysfunction occurs, then it may sign for hereditary hemochromatosis, which is an autosomal recessive disease carried by excessive GM which is absorption of iron, then hemosiderin deposits of hemosiderin, it includes liver disease, pigmentation, diabetes, pituitary hormone deficiency, central hypogonadism, arthritis, and cardiomyopathy. That's just arthritis. So this is thought to be caused by iron deposition in the articular cartilage and synovium with subsequent free radical damage and special deposition. It involves second and third MCP joints, in contrast to osteoarthritis of the hands, which is much more the PIP and DIP joints, and the first metacarpal pharyngeal joint. So, first metacarpal joint and pharyngeal joint, metacarpal and pharynx. So this joint between the fingers and the metacarpals. So the first is affected by osteoarthritis. Second and third are most commonly involved by hereditary hemochromatosis. X-ray findings include characteristic deformity like hook-like osteophytes. There is hook-like osteophytes, and so hook-like means iron-like, nail-like, and so iron-like osteophytes can be present. Deposition of calcium pyrophosphate diuret in the articular cartilage. So calcium phosphate diuret can deposit in the articular cartilage. Okay, so there is hook-like osteophyte. All right, makes sense. Acidic protein, so hepatocytes, hemosiderin accumulation, so iron. There is increased ferroportin activity, decreased hepcidin activity, and DMT expression is also more. Therefore, iron overload occurs, acidic mutation occurs. So hepatocytes accumulate hemosiderin. Okay, so Gowry arthritis may occasionally present as chronic arthritis of the small joints of hands and feet. Superficial resembling or rheumatoid arthritis. X-ray often shows associated bone erosions. So yeah, however, most patients have the acute gout attack, and fatigue and sexual dysfunction does not occur. So fatigue, sexual dysfunction does not occur in gout, but rather it occurs in a disease called hereditary hemochromatosis. Juxtaarticular polyarticular erosion. So juxtaarticular polyarticular erosion can occur. So this is juxtaarticular polyarticular erosion. Okay, and sesamoid bones. Multiple myeloma occurs in older patient and is rare at age less than 50. Multiple myeloma doesn't occur in less than 60 years of age. It includes scattered osteolytic lesions, so relucent lesion can be seen, especially in the axial skeleton in the vertebra. Reactive arthritis typically present with asymmetric oligoarthritis. So oligoarthritis occurs, enthesitis occurs, inflammation of tendons or tendon ligament insertion sites. So inflammation of tendon ligament insertion sites and dactylitis, sausage disease. So what occurs in reactive arthritis is here asymmetric oligoarthritis. So asymmetric oligoarthritis, small joints are involved. So few joints are involved. Asymmetrically. Enthesitis occurs. Enthesitis occurs. Enthesitis means inflammation tendon ligament joints insertion sites, and dactylis occurs. So sausage disease occurs. It is often associated with extra arterial symptoms including conjunctivitis, uveitis, and urethritis. Symptoms usually resolve within a few months and would not be chronic. Rheumatic fever, immunity accumulation, streptococcus infections, cardiac migraine arthritis, carditis, nodules, rash, marginal in Korea. It most commonly occurs at age 5 to 15 years and presents acutely 2 to 4 weeks after untreated pharyngitis. All right, next point. Now let's talk about acute rheumatic fever. It is a very common topic and an easy topic as well. Acute rheumatic fever occurs. It is an endemic in developing countries. Occurs after 2 to 4 weeks after acute group A towards pharyngitis, and there is M antigen, which is present in the structural antigen, and it is similar to cardiac neuronal antigens. So molecular mimicry occurs and causes the Jones criteria: migratory arthritis. So occurs pancreatitis occurs, cinnamon scoria occurs, mitral stenosis also occurs. Prevention from treatment with penicillin is the treatment. Okay, so ARF is most likely diagnosed in the patient with migratory arthritis, new onset murmur, fever, and positive ASO titer. ARF is a multisystem complication that develops 2 to 4 weeks after untreated group A streptococcus pharyngitis. Most organs are often only mildly and transiently affected in ARF, with the exception of the heart. So only mild effects it's seen. Acute morbidity is most likely due to pancreatitis. So morbidity is due to pancreatitis. So in terms of the endocardium, myocardium, and epicardium, in terms of the mitral valve can lead to mitral regurgitation, which is a likely cause of the new holocytic murmur. So if there is holosystolic murmur during systole, mitral valve can bounce back, therefore leading to a continuous murmur during systole, which is the holosystolic murmur. Can be definitely present in a patient. Severe regurgitation and or myocarditis can cause cardiac dilation. So myocarditis, if occurs for a long time, or regurgitation if occurs chronically, can lead to cardiac dilation, heart failure, and death in a small percent of patients. Okay, M proteins activation of P and CD plus cross-reactive response occurs. So there is carditis. So carditis or myocarditis with ESCOF bodies can be present in the heart. Okay, and valvulitis can also occur. Yeah, virtually all cases of mitral stenosis are caused by fibrosis. So all cases of mitral stenosis, narrowing of the mitral valve can occur because of fibrosis of the valve leaflets in chronic rheumatic heart disease. The fibrosis occurs gradually over years or decades after the initial episodes of ARF and would therefore not be an acute complication in this patient. Acute PSGN, that is post-streptococcal glomerulonephritis, is caused by circulating immune complex following a pharyngeal infection with specific nephrogenic strain. So PSN occurs because of streptococcus pharyngeal infection, with especially of the nephrogenic strains. Hematuria, edema, proteinuria, hepatitis and classical findings. Hematuria occurs, so 24-hour blood should be collected and looked for. Edema occurs is similar to nephrotic spectrum, therefore edema occurs, proteinuria occurs, and hepatitis also classical findings. This patient has no symptoms of PSN, which rarely occurs several days of their ARF. Patient's septic arteries are often febrile and ill appearing. Staphylococcus aureus is the most common agent. Septic shock referred to enormous damage due to poor provision from overwhelming response to infection. Although the pathogen's appearance involves an initial infection of group A streptococcus, the disease is autoimmune related, not due to direct infection. Okay, osteoporotic fractures. So medications are to do with osteoporotic fractures. You see, so osteoporosis medications to do with osteoporotic fractures. Let's search for drugs causing osteoporosis. Drugs for osteoporosis. No, no, no. It's not. Let's just watch a video on osteoporosis.
Osteo refers to bones, and porosis means pores. So osteoporosis is when there's a higher breakdown of bone in comparison to the formation of new bone, which results in porous bones, meaning a decrease in bone density to the point of potential fracture. Looking at a cross-section of a bone, there's a hard external layer known as the cortical bone, and a soft internal layer of spongy bone, or trabecular bone, that is composed of trabeculi. The trabeculi are like a framework of beams that give structural support to the spongy bone. The cortical bone, in turn, is made up of many functional, pipe-like units called osteons, which run through the length of the bone. In the center of these osteons, there are hollow spaces called conversion canals, which contain the blood supply and innervation for the bone cells. Around the conversion canals, there are concentric lamellae, which look a bit like tree rings. The lamellae have an organic part, which is mostly collagen, and an inorganic part called hydroxyapatite, which is mostly calcium phosphate. In between neighboring lamellae, there are spaces called lacunae, which contain bone cells called osteocytes. At first glance, bone may appear inert and unchanging, but it's actually a very dynamic tissue. In fact, spongy bone is replaced every 3 to 4 years, and compact bone is replaced every 10 years, in a process called bone remodeling, which has 2 steps: bone resorption, when specialized cells called osteoblasts break down bone, calcium levels, which in turn are kept in the normal range by a balance between parathyroid hormone, or PTH, calcitonin, and vitamin D. Parathyroid hormone is produced by the parathyroid glands in response to low serum calcium, and it increases bone resorption to release calcium into the bloodstream. On the other hand, calcitonin is produced by the thyroid gland in response to high serum calcium, so it opposes the action of PTH, therefore promoting bone formation and decreasing bone resorption. Finally, vitamin D promotes calcium absorption in the gut, so it increases serum calcium, promoting bone formation and decreasing bone resorption. The balance between these regulatory factors results in a peak bone mass, usually by age 20 to 29, and this usually occurs earlier in females than in males. Factors that determine the peak bone mass are genetics and nutrition. Being adequate vitamin D intake increases bone peak mass. Finally, strength training increases peak bone mass, as well as hormones like estrogens and androgens that inhibit bone resorption. Okay, now when osteoclasts break down bone faster than the osteoblasts can build it, it results in a lowering of the bone mass and eventually in osteoporosis. If we zoom into a cross-section of an osteoporotic bone, it will show normal cells with normal mineralization, which differentiates it from osteomalacia, where there is a lack of mineralization. So in osteoporosis, abnormal findings include fewer trabecular in the spongy bone and thinning of the cortical bone, as well as the widening of the conversion canals. These bone changes increase the risk of fracture and can cause fragility or pathologic fractures. Symptoms like the front shoulder blades, and ribs consist mainly of spongy bone, so there are great risk of fragility fractures. Factors that accelerate bone mass loss and increase
so the drugs that were discussed in the question, causing decreased amount of calcium, decreased calcium in the body. So any drug that causes decreased amount of calcium in the body can result in during osteoporosis, like glucocorticoids that decrease calcium absorption from the gut, heparins, and L-thyroxine.
In a zero gravity environment where they just don't use their musculoskeletal system as hard as when they're on Earth. As a result, bone getting decreases stress. Diseases that can cause osteoporosis, like Turner syndrome, hyperprolactinemia, Klinefelter syndrome, Cushing syndrome, and diabetes mellitus. Now, the two most common types of osteoporosis are
Okay, so medication associated with osteoporotic fractures, like vitamin D catabolism. So there should be decreased amount of vitamin D. So anticonvulsants that induce cytochrome P450. So anything that induces cytochrome P450 enzyme can cause increased amount of vitamin D catabolism, like phenobarbital, phenytoin, carbamazepine. So carbamazepine, phenobarbital, and phenytoin. So phenytoin, phenobarbital, and carbamazepine, all three of them increase vitamin D catabolism because they induce cytochrome P450 systems in the liver. Aromatase inhibitors and methoxyprogesterone. So aromatase inhibitors, aromatase is an enzyme that helps in the synthesis of estrogen, but if inhibitors are given like letrozole, then it decreases estrogen and therefore leading to osteoporosis. And GnRH antagonist, GnRH antagonist. GnRH is a very essential hormone in synthesis of, let's say thyroid hormone. So GnRH agonist. So GnRH agonist produces more amount of GnRH, the thyroid hormone. Thyroid causes increased amount of metabolism, therefore leading to decreased amount of calcium and osteoporosis factors, or decreased testosterone and estrogen occurs. So estrogen is less, therefore estrogen, because estrogen is less, so gonadotropin means estrogen. So gonadotropins like testosterone and estrogen are less, therefore results in osteoporotic factor. Proton inhibitors decreases calcium absorption, and glucocorticoids decreases bone forms as well as decreases calcium absorption. Insoluble calcium, calcium carbonate requires an acidic environment for protein. Insoluble calcium, so insoluble calcium like calcium carbonate requires acidic environment. So calcium carbonate requires acidic environment for proper form absorption. So insoluble calcium requires acidic medium for proper absorption, but PPIs may decrease the absorption of pediatric calcium in the diet because it decreases the acidic environment. Long-term use is linked to osteoporotic fracture. The risk greater in older patients in whom calcium absorption is already reduced, and those with respect to osteoporosis. Okay, medications like glucocorticoids can also induce it. Estrogen can also play an important role. Like aromatase inhibitors, agonists, they decrease estrogen, therefore leading to osteoporosis. Anticonvulsants like phenytoin and carbamazepine also decrease or cause osteoporosis. Okay, levetiracetam does not induce P450 system and has not been so to negatively affect bone mineral density in adults. Okay, levetiracetam is not associated. So statins do not increase the risk of osteoporosis. Now, thyroid diuretics can be used in the treatment of osteoporosis because it increases the reabsorption of calcium from the distal tubule and also stimulates osteoblast. And similarly, beta blockers like metoprolol may slightly decrease the risk of osteoporosis, possibly due to increased formation and decreased resorption of bone. So beta blockers may slightly decrease. Thiazide are implicated in itself. Nitrates, I mean, some study with increased bone density, decreased bone tumors occur, but nitrates, beta blockers, they are not the primary osteoporotic treatment strategies. So back and upper limb. So back and upper limb muscle. So you see there is a deltoid. So there's a deltoid muscle. This is an infraspinatus. So there's a spine in the scapula. So below the spine, this is infraspinatus and triceps in the back. So deltoid is present, infraspinatus and triceps. Trapezius muscle is present, that runs from upper part to the lower part, or into the vertebral body. Latissimus dorsi. So trapezius from the upper part, latissimus dorsi from the lowermost part. Similarly, deltoid, infraspinatus and triceps. And these are important. Trapezius and latissimus dorsi, deltoid, infraspinatus and triceps. They are some important back muscles. Latissimus dorsi is a large thoracolumbar muscle that contributes to the forceful movement of the humerus. So latissimus dorsi helps in forceful movement of the humerus. So humerus moves because of latissimus dorsi. Alright, it originates in the broad area spanning from the iliac crest. So it originates from, see, this is a muscle, latissimus dorsi is a muscle originating from iliac crest. So originates from iliac crest in the lowermost part, and lumbar fascia. So it also occurs from the lumbar fascia to the spinous process of T7 to 12. So spinous process of T7 to 12 and lower ribs, so as well as lower ribs. So these are lower ribs, and lower ribs also contribute to the origin of latissimus dorsi. It inserts in the bicipital group of the humerus. So insertion in the bicipital group of the humerus. So this is the humerus and bicipital group. So bicipital group is present in the humerus itself. So okay, latissimus dorsi innervated by thoracodorsal nerve. So thoracodorsal nerve, there is a nerve which is called thoracodorsal nerve. Thoraco means thorax, means okay, and dorsal means in the back. So thoracodorsal nerve is present in the back. It is innervated by thoracodorsal nerve with fibers originating from the C6 to C8 nerve roots. So thoracodorsal nerve is present, which originates from C6 to C8 nerve roots. Primary function includes, so extension occurs, not flexion, but extension. So extension occurs, abduction occurs, internal rotation of the humerus occurs. So internal rotation of the humerus, abduction and extension is facilitated by latissimus dorsi. It is a broad area and exposed location. Latissimus dorsi is vulnerable to injury from external trauma. It is frequent injury in sports requiring forceful downward movement of the humerus, such as throwing, climbing. So throwing, so forceful downward movement of the humerus, causing activities like throwing, okay, climbing, okay, swinging in tennis racket overhead. So all of these results in injury to thoracodorsal nerve, and hence the injury to latissimus dorsi. Deltoid is generated by axillary nerve, and primary function is to abduction of the arm. It can be injured due to sudden forceful loading of the arm while in abduction. So while so if the soldier is in abduction, and then there is forceful loading of the arm, then it can cause deltoid injury. Infraspinatus is innervated by the suprascapular nerve. So infraspinatus is innervated by scapular, but suprascapular, that runs upward. So suprascapular nerve and serves to external load of the arm. So infraspinatus helps in external rotation of the arm. Is most commonly injured in association with the supraspinatus. So it's most commonly injured in association with the supraspinatus due to falls or overage in older patients. So due to fall or overage in older patients, is infraspinatus can be injured. Trapezius allows in the upper back and neck, that's so to elevate, rotate, and stabilize the scapula. So elevation of the scapula, as well as rotation of the scapula, as well as stabilization of the scapula is helped by trapezius muscle. It is primarily innervated by cranial nerve number 11. The trapezius is frequently injured in whiplash motor vehicle accident. So it is present in the neck, so whiplash accident can injure it. Triceps is innervated by radial nerves, C6 to C8 and T1. So C6 to T8 and T1. Okay, then primary muscle in the extension of the elbow. All right, osteomyelitis. So see, progression of hematogenous osteomyelitis. So from the blood route, blood infection like staph aureus gets spread into the bacteriocerium leads to focal marrow cellulitis. First, there is focal marrow cellulitis. So this is physis, epiphysis, and metaphysis, but marrow cellulitis occurs first. Intermedullary pressure increases inside the medulla. The pressure increases, and then decreases blood flow and necrosis occur. Cortical and periosteal spread occurs, which now leads to retained necrotic bone sequestrum inside the bone and reactive bone formation, which is called involucrum. There is a draining sinus as well in the chronic sequel of the osteomyelitis. So child with acute onset fever, malaise, and refusal to bear weight. Findings concern for osteomyelitis. So a child with fever, refusal to bear weight, and malaise, they are linked towards osteomyelitis. Older children often have focal bony tenderness, but children age less than 2 may be unable to localize pain. Okay, for passive range of motion of the joints typically is normal. So passive range of motion of the joint is normal and helps distinguish osteomyelitis from septic arthritis. So in septic arthritis, even the passive movement of the joint is painful, while in osteomyelitis it is not, but rather weight bearing becomes painful. Most common is hemorrhages spread of the bacteria, which is induced by minor trauma at the site. Infection in the children classically occur in the metaphase of the long bones, primitive because it's highly vascular and contains slow flowing sinusoids. So slow flowing sinusoids are present that are conducive to bacterial seeding. So bacterial seeding of the within the metaphase initially causes acute inflammation of the bone marrow with focal hyperperfusion and increased radiotracer uptake within the affected region. So there is inflammation of the metaphysis of the bone. So persistent inflammation, that is chronic inflammation, leads to increased medullary pressure. So pressure increases, compromises blood flow, and that there is a dead bone inside the marrow. So which is called involucrum. Infectious activity into the cortex. So this is infectious activity goes into the cortex and the periosteum forms involucrum, which is the reactive bone formation. So chronic suppurative, and later sinus can form. Negative bone is sequestrum, and sinus tract can also develop. Osteomyelitis of the flat bones is uncommon in children. So flat bones is called pelvis. Their osteomyelitis is very uncommon and is caused by infection. Although pelvic bone movement may lead to refusal to bear weight. So pelvic bone movement can also lead to a refusal to bear weight. But this patient has no gross or abnormality of the hip or lower extremities, suggesting adjacent soft tissue infection. Ewing sarcoma, okay, typically occurs in the diaphysis of the long bone, especially in the femur. It is the second most common malignant bone tumor in children after osteosarcoma. So second most, very common tumor, second most common. So they present in children more than 10 years of age. So more than 10 years of age with incidence onset of progressive pain, not in toddlers. So toddlers do not suffer from Ewing sarcoma with acute refusal to bear weight. So next point is about physis. Physis in children limits vascular connections between the metaphysis and epiphysis, which is relatively less vascularized, making epiphyseal movement uncommon. So vascular connection between the metaphysis and epiphysis, which is relatively less vascularized, making epiphyseal involvement uncommon in hematogenous osteomyelitis. Avascular necrosis of the proximal femoral epiphysis. So proximal epiphysis, so avascular necrosis can occur in Perthes disease. Avascular necrosis occurs in Perthes, leg called Perthes disease. In leg called Perthes disease, there can be avascular necrosis. Avascular necrosis of the proximal femur. So they can be pain, limp pain is typically more mild and gradually until fever. So without fever. So there is just mild pain because there is just a necrosis of the avascular necrosis of the femur. Therefore, it is not much pain. There can be limp and pain, but it's very gradual, and fever does not occur. Emergent osteomyelitis in adults commonly occurs in the vertebral bodies due to increased vertebral vascularity with age, as well as epiphyseal closure during puberty. So epiphyseal closes during puberty, therefore improves cavity flow within the metaphysis of the long bones. Okay, so okay, lipoma, like by the soft mobile softness mass, constitute of mobile mass. They are very common benign tumor that are less often fact. They typically occur in middle adults and are generally stable and last slowly over time. The upper lying epidermis is normal. Diagnosis is very easy, clinical, and external biopsy can be performed, well differentiated. Mature adipocytes with the intact fibrous capsule may be present. Because lipomas are generally harmless, most can be left in place, although excision can be considered for cosmetic reasons or patient discomfort. Alright, so mature adipocytes with small peripheral nuclei. Okay, osteosarcoma is usually seen in children and young adults. So osteosarcoma is a common tumor in children. So osteoma can occur in children and young adults. It is uncommon in older adults, and in which it is often associated with prejudice of bone. So if osteosarcoma is the commonest bone tumor in children, occurs in adults, then it is generally associated with prejudice of bone, presents with more local pain and swelling. Mass palpable is non-mobile. Histopathology shows pleomorphic malignant cells with hyperchromatic nuclei forming neoplastic osteoid bone. So neoplastic osteoid produced by tumor cells. So this is neoplastic osteoid. So this reddish color is neoplastic osteoid. So there is bone forming cells. Osteoid is formed produced by the tumor cells, malignant tumor cells. They are malignant tumor cells. Okay, hyperchromatic nuclei. So these are tumor cells. Okay, so erythema nodosum presents acutely as tender suppleness nodules in the lower extremity. So erythema nodosum. What is erythema nodosum? It is leprosy nodosum. So it is similar to leprosy. So suppleness nodules in the lower extremities. It occurs in association with various infections like herpes simplex and inflammatory conditions. So various variety of infectious and inflammatory conditions. Histopath shows inflammation of the subcutaneous paniculatis occurs. So in erythema nodosum, paniculatis occurs. So subcutaneous fat infection or inflammation of the subcutaneous fat occurs with edema, fibrinous exudate, a variable cellular infiltrate. So there is inflammation. So there is inflammation, subcutaneous fat, so subcutaneous fat inflammation, fibrinous exudate, and variable cellular infiltrate. So variable cellular infiltrate with neutrophils, lymphocytes, and histiocytes. So this is erythema nodosum. Tender subcutaneous nodule can occur because of paniculatis, subcutaneous fat inflammation. Okay, all right. Cutaneous squamous cell carcinoma typically forms an enlarging epithelium, so epidermal nodule in sun exposed areas. So SSCs form epidermal nodule in sun exposed areas. They develop a thick, rough surface or ulcer with crusting and bleeding. Pathologic finding to seeds of eosinophilic squamous cell with keratin present intercellular bridges. Rough ulcerative lesion, and intercellular breaches. So they are intercellular breach, cell breaches, other mitotic figures can be present, keratin pearl is present, epidermis is present, nest of malignant squamous cells invading dermis can also be seen. Cutaneous neurofibroma, usually manufacturing early adolescence, as raised fleshy tumors, so less than 2 centimeter tumors that often increase in size and number with age. So that often increase in size and number with age. Oh, all right, they're composed primarily of Schwann cells. Schwann cells are spindle cells with wavy or serpentine nuclei, fibroblast, and perineural cells. So they're composed of primarily of Schwann cells. So what is cutaneous neurofibroma? Cutaneous neurofibromas raise fleshy tumors. They are raised fleshy tumor that often increase in size and number with age. So they're composed primarily of Schwann cells. So cutaneous neurofibroma are composed of Schwann cells. Schwann cells are spindle-shaped cells with wavy or serpentine nuclei. So what is Schwann cell? This is spindle-shaped cells with wavy or serpentine nuclei. Their fibroblasts also present and perineural cells are also present. Perineural cells are also present. So this is a Schwann cell. This is cutaneous neurofibroma. Okay. Information: raised soft fleshy tumors. Raised soft fleshy tumors less than 2 centimeters in size. And neurofibromas, Schwann cells are present, and because they are spindle shaped, they represent Schwann cells. All right, and collagens can be present, perineal cells can be present. Now let's talk about reactive arthritis. So reactive arthritis. Let me search about reactive arthritis. Let's see a video on reactive arthritis.
New Kellogg's Smoothie. 12 great fruits, nuts, and seeds for energy. The biological power breakfast.
Sorry for that, guys.
Reactive arthritis, formerly known as Reiter syndrome, is inflammation of a joint which usually develops after an infection. And that infection is typically a sexually transmitted disease or gastroenteritis. Reactive arthritis is part of a group of diseases called seronegative spondyloarthropathies. Spondyloarthropathies are autoimmune inflammatory joint diseases, and they're seronegative, which refers to the fact that an autoantibody called rheumatoid factor is absent from the blood. Normally, the immune cells are ready to stop and destroy anything foreign that can cause the body harm. To help with this, most cells in the body have a set of proteins that combine together to form something called a major histocompatibility complex, or MHC. And this is a molecule that sits on the surface of their cell membrane. There are two kinds of MHC molecules, class 1 and class 2. Class 1 molecules are found on most cells in the body. They present molecules from within the cell for the immune system to continually sample. Normally, that molecule is just a sample from inside the cell, also known as a self-antigen. When immune cells pass by, they recognize this self-antigen as harmless, so there's no response. MHC class 2 molecules are found specifically on phagocytic cells, like macrophages, which destroy and digest foreign pathogens like bacteria. Once a macrophage destroys bacteria, it presents a piece of that bacterium on its MHC class 2 receptor, and the macrophage then makes its way to the lymph node and finds its T lymphocytes. A type of T lymphocyte called the CD4 positive T cell, also known as a helper T cell, uses its T cell receptors to bind to the foreign antigen presented by the MHC class 2 molecule. If the helper T cell binds strongly, the antigen is recognized as foreign, and the helper T cell switches on the corresponding B cell, so it can start producing a whole lot of antibodies. These antibodies bind to a specific pathogen, and typically prevent it from attacking the host cells. At the same time, they tag the pathogen for further destruction by other immune cells. Reactive arthritis can develop after a sexually transmitted infection, like chlamydia, or after gastroenteritis caused by bacteria like Salmonella, Shigella, Yersinia, Campylobacter, and E. coli. These bacteria are all gram-negative, so they have molecules on their member surface called lipopolysaccharide, sometimes called LPS. These LPS molecules produce a strong immune response, so much so that their other name is endotoxin. Also, most individuals with reactive arthritis have a specific gene, HLA-B27, which is one of many genes that has code to make MHC class 1 receptors. HLA-B27 is also associated with other inflammatory diseases, like psoriasis and ankylosing spondylitis. Exactly how reactive arthritis develops, however, is still unclear, but it probably has something to do with the way that lipopolysaccharides bind the MHC molecules on cell surface. Now, because the immune system takes a little while to present foreign antigens and get T cells in the game, reactive arthritis often starts 2 or 3 weeks after an initial infection. Tissues usually targeted by the immune system are tissues in the joint spaces, but occasionally the immune system also attacks tissues underlying the immune triangle contact. In fact, all 3 of these tissues are affected, including the joint spaces, the immune triangle, and the IgE. That causes a triad which associates arthritis, dermatitis, and conjunctivitis. However, this triad is very uncommon, and usually only the joint spaces are affected. Other tissues that are sometimes involved include the cervix and women, and the pericardium of the heart. Symptoms of reactive arthritis may be Less often, it can involve other joints like the ankles, hips, and small joints when moved, or affect multiple units. Other symptoms could include pain and urination, when your threats are present, and presence in the eyes, like conjunctivitis, but these are less common. Higher medical surface area steaming, which smells being examined as a surface. Or as a quick recap, Rheumatoid arthritis has been infection.
All right, I think it's understood. GI infection. So reactive arthritis occurs with GI infection like GI urinary infections, gastric infection. Sorry, sorry, genital urinary infection like chlamydia, trachomatis, and enteritis like Salmonella, Shigella, Yersinia, Campylobacter, Clostridoides, formerly Clostridium difficile. Muscular asymmetric oligoarthritis occur, enthesitis occurs, asymmetric oligoarthritis, enthesitis and dactylitis can also occur. So on the dividis occurs, urethritis occur, keratoderma breve, so rash in the feet occurs, circular balanitis occurs in the penis occurs, and also can also pretty common. So urethritis, conjunctivitis, and mono oligoarthritis considered triad of reactive arthritis. The seronegative, rheumatoid factor negative, spondyloarthropathy most commonly affects patients is 20 to 40 and is with SLB 27. So it is seronegative, that is rheumatoid factor negative. So seronegative means rheumatoid factor negative, but SLB 27 positive. So symptoms generally manifest 1 to 4 weeks following the primary infection, causing urethritis or enteritis, and can be caused by autoimmune reaction by initiated by the infected pathogens. So by the lipopolysaccharide. So in fact, skin finding in keratoderma, so blenurasic, hyperkeratic vesicles in palms and soles, and serpinous serpinous annular dermatitis of glans penis. So there is a glans penis and there is serpinous annular serpinous round like annular dermatitis, the glans penis, which is called circinate and circular balanitis. Okay. So exit involvement in sacroiliitis may occur about 20% cases. Esophageal dysmotility. So esophageal dysmotility is classic finding in scleroderma. So in scleroderma can cause esophageal dysmotility, although it can occur in other conditions as well. Hyperparathyroidism may occur in settings of multiple endocrine neoplasia. So hyperparathyroidism can occur in MEN. So polymyositis may occur in setting of dermatomyositis. So polymyositis, so multiple muscle inflammation can occur in setting of dermatomyositis or as a separate entity, and polymyositis can occur as dermatitis or as a separate entity, and tabes dorsalis is a manifestation of tabes dorsalis. Tabes dorsalis is a manifestation of dorsal syphilis. Secondary syphilis causes maculopapular or pustular but not vesicular rash. So it is a very important fact. So vesicular rash does not occur, but rather maculopapular or pustular rash occur. Talking about palms and soles, it is generally associated with polyarthritis. Monoarthritis is very rare, and polyarthritis can occur. So, risk factor for osteoarthritis. Okay, so risk factor of osteoporotic factors. Osteoporotic factors. There are non-modifiable factors and potential modifiable factors. So, non-modifiable factors like advancing age, or senile, or osteoporosis, female sex, white, Hispanic Asian ethnicity, personal or family history of fracture. So, potential modifiable factor: decreased physical activity causes more disruption of the bone, low body weight. So, low body weight. Can also cause osteoporosis fracture, poor calcium vitamin D intake, excessive alcohol, tobacco use, premature menopause, early menopause, or glucocorticoid use decreases calcium absorption can result in osteoporosis. Now, bone mass in osteoarthritis is determined by peak bone mass and the subsequent rate of bone loss. Most of the variation in peak bone mass is genetically determined. So, how much bone or strong the bones will be is genetically determined, but environmental factors such as nutrition status, like calcium vitamin D intake, and physical activity also have a significant impact. Establishment of high peak bone mass during early adulthood is important because of bone mass subsequently declines with age. Conventionally, osteoporosis means less than 2.5 T score, and for peak compared to peak young but bone adult density. So yeah, this is how things progress. Okay. Solution group A shows higher peak bone mass. So solution group A shows higher peak bone mass. So this is high. All right. So this is high. This is high, while slightly slower, so be slightly slower rate of peak bone mass loss. So peak bone loss is very slightly lower. So peak bone mass is slightly lower means lower peak bone mass is slightly lower decreasing, and higher late life and bone mass than the supporting group B. This is considered with the effect of regular exercise, especially weight-bearing exercise. In contrast, factors that lead to lower pigment mass include genetic and ethnic factors, chronic inflammatory disease, and glucocorticoid medications, and sedentary lifestyle. In addition, prolonged caloric deficit seen often with excessive exercise can lead to functional hypothalamic amenorrhea. So, functional hypothalamic amenorrhea can occur. Prolonged calorie deficits. If a patient does not eat, or if a patient exercises too hard, it can lead to functional hypothalamic amenorrhea, suppression of estrogen production, and rapid bone loss. Estrogen have an anabolic effect on bone by increasing osteoblastic activity and decreasing osteoblastic activity. So similarly, loss of estrogen in failure menopause, premature ovarian failure can accelerate bone loss. Bone density is proportional to BMI. So BMI less than 22 is associated with increases of osteoporosis, or weight less than 56, 57.6. So BMI less than 22 means has higher chances of osteoporosis, smoking accelerated bone loss, and causes fractures as well. Chronic glucocorticoid use, major factor of risk factor for osteoporosis. And they decrease the calcium absorption, inhibit collagen synthesis by osteoblasts. So osteoblasts cannot now synthesize collagen and decreasing GNR. So hypogonadism can also occur, and increased urinary calcium loss also occurs. Now let's talk about Duchenne's muscular dystrophy. This is Gowers sign. Okay, thigh atrophy occurs, and using hands to push on legs to stand. Deletion of dystrophin gene cause Duchenne's muscular dystrophy (DMD). Accident disease primarily affects the boys. So the boys are the most common affected groups. Dystrophin is a structural protein in the muscle fibers, and its absence causes muscle fiber destruction, myonecrosis, variation in muscle fiber shape and size, regenerating fibers, and increased amount of connective tissue, as seen in light microscopy. Disease onset is age 2 to 5. Muscles of the proximal lower extremities, back and pelvic and shoulder girdles are affected first. Symptoms of DMD include the following. So you see proximal muscles, back and pelvic and shoulder girdles affected in Duchenne's muscular dystrophy. Ambulation difficulties, clumsy, slow, the waddling gait, and continue to keep up with peers. Gowers is present. So progressive weakness of proximal musculature, leading use of distal hands to support weight and standing. Calf pseudohypertrophy occurs. They replace the fat and connective tissue. Calf muscles hypertrophy initially in response to proximal muscle weakness, and later fat and connective tissue replace it. And oxidative weakening of paraspinal muscle leads to kyphoscoliosis. Kyphoscoliosis can also follow. Most patients with DMD are wheelchair bound by age 12. So wheelchair bound by age 12. So 12 wheelchairs. Scoliosis progresses rapidly due to muscle imbalance. So scoliosis progresses rapidly due to muscle imbalance and body postural changes. Worsening scoliosis complemented by restrictive pulmonary function. So the scoliosis as well as because of scoliosis, lungs size is markedly reduced and cause restrictive lung disease. Hypertrophy of muscle fibers may occur in early stages of DMD. So hypertrophy of muscle fibers may occur in early stage of DMD. However, fibrobody changes in the late stage. Lipid accumulation occurs in lipid myopathies like carnitine palmitoyl transferase deficiency. So in carnitine palmitoyl transferase deficiency. Carnitine palmitoyl transferase deficiency. In carnitine palmitoyl transferase deficiency. Lipid accumulation in the muscle fibers. So, okay, lipid accumulation in the form of muscle fibers occur in carnitine palmitoyl. So, carnitine palmitoyl transferase deficiency. Prominent inflammatory infiltrate. So, prominent inflammatory infiltrate is a characteristic. So, inflammation of the histopathology, characteristic histological features of polymyositis and dermatomyositis. Polymyositis and dermatomyositis leads to inflammation of the muscles. This condition causes proximal muscle weakness without distal pseudohypertrophy. Ragged red fibers refer to muscle fibers with irregular contours and a blotched red appearance. So ragged red fibers. Refer to muscle fibers with irregular contours and blotchy red appearance. So ragged, they are seen in mitochondrial. So ragged red fibers are seen in mitochondrial myopathy. So mitochondrial myopathy is raised to ragged red fibers. So ragged red fibers occur in mitochondrial myopathies. Now let's talk about job stress. I think I should watch a video. Okay, this one is a very easier form of video. Which video shall we watch? So this is a very long video. Let's watch a very short video. Let's watch the first video.
Church-Strauss disease is another type of vasculitis. This vasculitis affects the small blood vessels. And vasculitis is vessel inflammation, which can lead to many different tissues being damaged. Church-Strauss shows a lot of common damage to different organs as other vasculitides. So, for example, like Wegener granulomatosis, you might see sinusitis or kidney issues or lung issues as well. Lung tissues may be damaged. And Eosinophils are white blood cells that react to allergies. Actually, under a microscope, staining
All right, so the patients mostly has eosinophilic, okay, granulomatosis with polyangiitis, chalk straws. This small to medium vessel vasculitis is characterized by late onset asthma occurs, rhinosinusitis occurs, eosinophilia occurs, though it can also affect kidneys, the tract, and cardiovascular system. Asymmetric multifocal neuropathy, multineuritis. All right, wait. Asymmetric multifocal. So there are various focal points neuropathy. Mononeuritis multiplex is particularly common due to vascular disruption in the epineural vessels. Reach dropped to radial nominal. So epinural vessels are involved, leading to mononeuritis multiplex. That is, wrist drop occurs due to radial nerve involvement. So other common manifestations include skin nodules. So other common manifestations include skin nodules, migratory transient pulmonary infiltrate. So skin nodules are present. Migratory transient pulmonary infiltrate. So skin nodules can be present. Long nodules or pulmonary infiltrates can be present. Paranasal sinus abnormality. So paranasal sinus sinusitis can occur. In addition to peripheral eosinophilia, frequent is P ANCA positive, neutrophil myeloperoxidase is positive, P ANCA staining is positive. Okay. Allergic bronchopulmonary aspergillosis (ABPA) can produce an asthma-like picture with eosinophilia and elevated IgE and IgG serum antibodies to Aspergillus fumigatus. And P ANCA is not commonly associated, and systemic vasculitis is also not present. Pulmonary involvement in antiglomerular basement membrane disease presence with cough, pulmonary infiltration, hemoptysis. So hemoptysis, not asthmatic symptoms. So hemoptysis occurs. Okay, antiglomerular basement membrane disease presence with cough is present, pulmonary infiltration is present, hemoptysis is present, not asthma-like. So hemoptysis and glomerulonephritis, both of them are very common features of antiglomerular basement membrane diseases. Patients have circulating autoantibodies against collagen 4. So they have circulating autoantibodies against collagen 4 basement membrane, against basement membrane, which damage alveolar and glomerular basement membrane. Carpal tunnel syndrome is characterized by paresthesia and pain in the distribution median nerve, sensory nerve. So radial nerve palsy is most commonly involved in Chaugi-Strauss syndrome, one not the medial nerve. Sensory symptoms are more prominent than motor symptoms during the initial presentation. Idiopathic pulmonary fibrosis is a chronic fibrosing interstitial lung disease. So idiopathic pulmonary fibrosis. So idiopathic pulmonary lung fibrosis is a chronic fibrosing interstitial lung disease. So idiopathic pulmonary fibrosis is a chronic fibrosing interstitial lung disease. There is no known association with P. ANCA, eosinophilia, or systemic vasculitis. So, all right, understood. Pulmonary fibrosis. Pulmonary parenchymal involvement. So, pulmonary parenchymal involvement by systemic sclerosis. So, systemic sclerosis can also involve lungs, resulting in chronic restrictive interstitial fibrosis. Anti-topoisomerase 1, SCL70, anti-centromere, and anti-RNA polymerase 3 antibody are very specific for systemic sclerosis. So, systemic sclerosis has three common antibodies in the blood. So the antibodies are anti-topoisomerase 1. So anti-topoisomerase 1, systemic sclerosis. So let's say this is systemic sclerosis. Systemic sclerosis has anti-topoisomerase 1, or SCL70. Similarly, anti-centromere. So anti-centromere, this is centromere of a chromosome. Anti-centromere, this is attack. So anti-centromere and RNA polymerase 3 and antibodies present in the blood. So this is how we diagnose systemic sclerosis. So now let's talk about Peyer's disease of the bone. Okay, Peyer's disease. This was a very small, short, and to the point video. There are very long videos all around. Okay, I think this is a short video.
Bone tissue is a tissue that is regenerated throughout life, and this regeneration process is called bone remodeling. Now, the bone remodeling has two steps. The first step of the bone remodeling process. Suggests that Paget's disease may be related to a slow virus infection of bone, a condition that is present for many years before symptoms appear. Associated viral infections include respiratory syncytial virus, canine distemper virus, and the measles virus. Paget's disease is also linked to genetic mutations, such as the SQSTM1 gene mutation. Normally, SQSTM1 gene encodes a protein involved in regulating osteoclasts. Now, Paget's disease has three phases, and the first phase is the lytic phase. In lytic phase, the number of osteoclasts increases, and also osteoclasts in this phase are larger than normal osteoclasts and have one nuclei, and these osteoclasts aggressively break down the bone up to 20 times more than normal. The second phase is the mixed phase. Mixed phase is characterized by rapid increases in bone formation from numerous osteoclasts. Although increasing number, the osteoclasts remain morphologically normal. However, the newly made bone is abnormal. It is collagen fibers deposited in a haphazard fashion rather than linearly, as with normal bone formation. Phase 3 is the sclerotic phase, and that's where new bone formation exceeds bone resorption. And the final result is bone that's structurally disorganized and therefore weaker than normal healthy bone. Eventually, the osteoclastic activity also slows down, and there's a normal state in the disease called the current bad state. Early on, Paget's disease in bone doesn't simply cause symptoms, but over time, the shape of bone significantly alters the pathway. In addition to the size of bone, the overgrowth of bone can make a person have a lion-like face, which is called myotasis. The bony overgrowth can also narrow the auditory foramen and impede the auditory nerve, leading to hearing loss. If there's bony overgrowth that impedes the optic nerve as it passes through the optic canal, that can lead to vision loss. Other bony deformities involve Paget's disease in bone, include kyphosis, which is an excessive curvature of the spine, making the person face down to the ground, lowering their muscle weakness from the shape of bone and compressing the spinal cord, and causing asymmetry. In many cases, Paget's disease is discovered incidentally or X-rays are taken or lab work is performed for some other reason. If this occurs, a doctor will perform a physical examination without undergoing tests like X-rays to confirm the diagnosis. X-rays provide images of construction, such as bone, because Paget's disease can usually be diagnosed by looking at X-ray. A bone affected by Paget's disease is usually and considered normal bone. It may also have a deformity. Other tests like serum, underlying phosphatase, may also be used to confirm the diagnosis. In patients with Paget's disease, underlying phosphatase levels are usually quite elevated. A biopsy is sometimes necessary to confirm the diagnosis of Paget's disease or rule out any conditions. In a biopsy, a small sample of the affected bones are removed and examined under a microscope. The procedure can be performed under minimal anesthesia with a minimum of swelling and inflammation. Treatment of Paget's disease in bone includes pain relievers as well as anti-absorptive medications like bisphosphatase, which slow down the bone passes. In addition, severely harming bone deformities, it can also lead to associated fractures.
Okay, and as bone, cranial artery impairment. So because of increased bone, cochlear enlargement occurs. Enlargement of head, fractures can occur. Cortical thickening. So vertebra can be affected, causing stenosis or narrowing of the blood, so bony canal, and osteoarthritis, bone deformities can also occur in beta stage. So older patients with multifocal bone pain has enlarged vertebral bodies with cortical thickening on imaging. So if there is more osteoblastic function, it causes cortical thickening on imaging, which is considered with the beta stages of bone. It is characterized by excessive and disordered bone formation, commonly affects the skull along with the extremities and vertebral column. In addition to pain and deformity, vertebral spinal stenosis can occur, nerve compression can occur, and compression fractures can also occur. Increased formation of new bone in paste is associated with ALPs are markedly raised. Blood changes occur slowly. Serum calcium and phosphorus levels are normal. Radiographs shows lytic or mixed lytic sclerosis, sclerotic lesions. Thickening of cortical and cervical bone can also occur in the late stage, in the osteoblastic stage, and bony deformities can also occur in the vertebra. Bony enlargement and cortical thickening may create appearance resembling a picture frame. So picture frame vertebra can also occur in the vertebra. So the levels of 25 hydroxy vitamin D reflects total body calcium, vitamin D stores, and is useful in the diagnosis of osteomalacia. So osteomalacia. So most important diagnostic marker in osteomalacia is 25 hydroxy vitamin D. So 25 hydroxy vitamin D is mostly is representative of total is representative of vitamin D stores in the body. In addition to bone pain, osteomalacia can cause muscle weakness, difficulty walking. Muscle weakness can occur, difficulty walking can occur. X-ray reveals diffuse demineralization, often with insufficiency fractures rather than cortical thickening. So no cortical thickening occurs. So ESR reflects circular level inflammatory proteins and is elevated in multiple inflammatory migraine conditions. It is classically elevated in polymyalgia rheumatica. So ESR can be raised, ESR can be raised in polymyalgia. So multiple muscle pain, rheumatica means because of autoimmune conditions. So they can cause pain in the shoulders, hips, and proximal extremities, but X-rays are normal. So X-rays is normal because of autoimmune. Because there is no any bony destructions, but rather muscles are damaged because polymyalgia is occurring. They can also be strikingly elevated in multiple myeloma. So X-rays ESR can also be increased in multiple myeloma, which can cause osteolytic lesions, or depositic lesions, but not cortical thickening. Hyperparathyroidism can present with bone pain, typically in association with hypercalcemic manifestation. So this the calcium can be increased. Constipation, renal stones can be present because of increased calcium levels in the body. And X-rays of vertebral column reveals cortical thinning, not so okay, not thickening. Prostate experiment is used to diagnose of prostate cancer, bone medicine, prostate cancer, and X-rays focal sclerotic lesions. So prostate cancer also produce sclerotic lesion. Most patients have palpable nodes and prostate examination, and this is how we diagnose it. So polyarteritis nodosa. Let's talk about PAN. I think I should stop it. And poly. Let's watch a very small video. I think this is it.
Anyway, this is a polyarteritis nodosa PAN. So this is what this condition is, how we can diagnose it, and how we can treat it. So PAN is an necrotizing vasculitis involving medium-sized vessels. So that's important. Necrotizing vasculitis of medium-sized vessels. It is an ANGA-negative condition, and it is associated with hepatitis B infections. However, it's only about 5 to 10% of cases that are associated with hepatitis B infections. So oftentimes there's an association, but it's not necessarily a strong one. So with regards to the epidemiology of PAN, there's a male to female ratio of around 1.5 to 2 to 1. So males are more affected. Usually can be double the number compared to females. Now, this condition typically occurs between these.
So PAN is associated with hepatitis B infection and is ANCA negative, or unlike Zolgastros, where it is P ANCA positive. P ANCA positive was present. All right.
And this condition has systemic involvement. Wherever there are medium-sized vessels, that's what is going to be affected. So it can be systemic. Oftentimes, the kidneys are the most commonly involved organ. And interestingly, this condition seems to smear the lungs. So some of the signs and symptoms of PAN include the following. So typically there are constitutional symptoms. So again, fatigue, weight loss, perhaps fever, chills, those types of symptoms. There can also be myalgia, so you're going to have feelings of muscle aches and cramps. There can be skin manifestations. Typically, you're going to get a liminal reticulosis, so you're going to get this kind of webbing type of look to your skin. And there can be neuropathy, so issues with sensation. So how to make the diagnosis of PAN? There isn't a specific criteria for diagnosis, but the American College of Rheumatology or ACR has particular criteria, and if you meet 3 or greater of these criteria, you can essentially say that this is a PAN or polyarteritis nodosa diagnosis. So what are some of these criteria? The first one is weight loss. Type of this as constitutional symptom. Typically, it's greater than 4 kilograms of unintentional weight loss with absence of other factors or conditions, and it has occurred since the beginning of the illness. Second is myalgia, weakness or leg tenderness. So we talked about earlier, either muscle weakness or muscle cramps. And typically, the myalgia are diffuse, and the weakness also diffuse as well. The third one is liminal reticulosis, that skin look of kind of webbing appearance. The fourth one is neuropathy. So it could be mononeuropathy, it could be mononeuropathy multiplex or polyneuropathy. The fifth one is testicular pain or tenderness. The sixth one is a diastolic blood pressure of greater than 90 millimeters per mercury. The seventh criteria is an elevated creatinine bun, so creatinine greater than 30, a bun greater than 40.3 millimoles per liter. So this leads into kidney being affected, what's called the eighth criteria is being hepatitis B positive. So just because there is a small association with 5% of cases, this could be used as a criteria for diagnosis. The ninth one is having an arteriographic abnormality, so you see something wrong on the image. And the tenth is an artery biopsy that shows presence of granulocytes plus or minus mononuclear lymphocytes in the artery wall. So these are the 10 PCR criteria. And anything you want to know, you could use these criteria to diagnose many people with polyarteritis nodosa. But really, it's all in the context of clinical presentation and having no other known conditions that are causing or influencing these types of presentation or criteria. So if there's nothing else, and you see all of these criteria, it may be polyarteritis nodosa diagnosis. So again, not a perfect criteria, but it's helpful to know these criteria and possibly use it for diagnosing patients with. So once you get a diagnosis of polyarteritis nodosa, how do you treat it? Well, treatment involves the use of steroids. And secondly, you also use cyclophosphamide as well. And in the cases where hepatitis B is associated or may be related to the diagnosis, you can use antivirals to treat the hepatitis B, which can help with the polyarteritis nodosa.
All right. So polyarteritis nodosa is medium vessel vasculitis, and macrophage. This is fibrin and transmural inflammation of the blood vessels. So there is transmural inflammation of the blood vessels. All the 3 layers of the blood vessels are affected. So they produce a beads on string pattern. So beads on string pattern is produced. So forms like a nodule. So polyarteritis, the multiple arteries, nodules are present. So it is therefore called polyarteritis nodosa. So in ischemia, necrotic fibrinoid material can be deposited. So there is necrotic fibrinoid material deposited, while in aneurysm, all the 3 layers are dilated. So this patient's systemic symptoms, renal his kidneys are very commonly affected. So renal small bowel infections, biopsy findings are considered polyarteritis nodosa. Systemic vasculitis of medium-sized muscular arteries. So, PAN is among the following: segmental transmural inflammation of the arterial wall with invasion of neutrophils and monocytes. So, there is transmural inflammation of the arterial wall, and all the 3 layers can be affected. So, there is transmural inflammation, destruction of the inner portion of the arterial wall with the normal arteries replaced with necrotic fibrinoid material. So, as seen here, so necrotic fibrinoid material deposits in the arterial wall and loose connective tissues. So loose connective tissues are also deposited, and which narrows the vessel limit and increases chance of risk of thrombosis and tissue infarction. So tissue infarction occurs. There is blood vessel supplying the blood vessel itself. So that is also affected, thereby leading to ischemia of the blood vessel. And thrombosis can increase the risk of thrombosis and tissue infarction, and destruction of the internal and external elastic laminae increase the risk of microaneurysms and subsequent rupture. So There's a destruction of the internal and external elastic lamina. So internal and external elastic laminae can also occur, which weakens the blood vessel, resulting in microaneurysms and subsequent rupture. Patients with PAN generally present with weeks or months upon specific constitutional symptoms: weight loss, fatigue, low-grade fever, arthalgia, small sinus tissue ischemia, the kidney renal infarction is very common. GI trouble, small bowel infarction is very common. So medium-sized blood vessels supply the kidneys and bowels, so they are affected. And mesenteric ischemia can also be affected. Peripheral nerves and skin is affected because PAN is not associated with ANCA and A neutropenic or significant elevation in ANA. So ANA antibodies and ANCA is not elevated. Therefore, diagnostic confirmation requires tissue biopsy, which shows fibrinal deposition of the blood vessel wall, and there is tissue ischemia as well. So similarly, bacterial endocarditis can cause embolic specific septic infarction in the kidney. So embolic septic infarction can occur in the kidneys and intestine. Bacterial endocarditis can cause embolism to form and leads to infarction, but the infarction is usually embolic in nature. And in the kidneys and intestines, inherited coagulation disorders. So inherited coagulation disorders can also cause thrombosis with tissue infarction. However, biopsy would show a clot or embolism in the arterial lumen. So there can be a clot in the arterial lumen during acute infarction, not transmural inflammation. So transmural inflammation is very suggestive of PAN and chronic tissue proliferation. So granulomatous with polyangiitis. So granuloma is formed with pills and multiple vessels are inflamed, usually cause manifestations in the upper lower airway. So rhinosinusitis and hemoptysis and kidneys glomerulonephritis. So transmural, and so in terms of it means a PAN, but rather granulomatous with polyangiitis cause manifestations in the upper lower airways. So okay, upper airway means sinusitis, and lower airway means hemoptysis, and kidneys means glomerulonephritis is also very common. The GI tract is not typically affected. Further, biopsy generally reveals us leucoclastic vasculitis, so leukocytoclastic, so leukocytic cytoclastic vasculitis with minimal or no liver narrowing of fibrillar necrosis. So there is no fibrillar necrosis, there is no liver narrowing. These granulomas are formed, but vessel narrowing is not present. Leukocytoclastic vasculitis is very common. So similarly, thromboangiitis obliterans occurs in young smokers. It's a Burgess disease. It occurs in young smokers. It's marked by inflammatory thrombi in the small. So thrombi is present in small and medium-sized vessels of the extremities. Therefore, so patients usually have digital ulcers, ischemia, gangrene, limb claudication, mesenteric and renal infarction will be atypical. So mesenteric and renal infarction. So these are medium-sized vessels. They are not affected. And in addition, transmural inflammation and chronic tissue proliferation would not be seen during acute stage of the infarction. All right, buddies. Let's talk about bone remodeling. So this is osteocyte, and this is osteoclast, which degrades the bone cells, formed by osteoblast, and there are bone lining cells. There are old osteoblasts and osteoid is the organic matrix secreted before bone formation. This is a new bone, and this is an old bone. There mineralization occurs, so resorption occurs, formation occurs, then mineralization occurs. So bone is continually broken down and reformed by the process known as bone remodeling, which consists of coordinated activity of osteoblast responsible for bone formation and osteoclast for resorption. The subjects in this study are receiving a recombinant parathyroid hormone analog. So subjects, if a study has subjects who are receiving recombinant parathyroid hormone analog, that is teriparatide, it is given intermittently, which should have rather stimulated osteoclast, but rather stimulates osteoblast. That the pre-osteoblast and osteoblast are stimulated. Okay, so osteoblasts now synthesize bone matrix and express alkaline phosphatase. So osteoblast now express also alkaline phosphatase, which promotes normal bone mineralization by increasing local concentration of inorganic phosphorus. So alkaline phosphatase increases the local concentration of inorganic phosphorus, thereby more bone mineralization becomes more rapid. Serum alkaline phosphate. So alkaline phosphatase level correlated with osteoblastic activity. However, total serum levels are non-specific, as ALPA is also produced by hepatobiliary tree, intestine, placenta, and may be elevated due to other regions like pregnancy, biliary obstruction, etc. If the source of ALP is uncertain, ALP isozymes like liver, placental, intestinal, bone. So the typical isotype of the isoenzymes of the particular enzyme, that is ALP, can be differentiated with additional laboratory techniques like electrophoresis, immunoassay. Other markers of osteoblastic activity include N-terminal polypeptide or type 1. So other osteoblastic activity is suggested by ALP. Similarly, others include N-terminal polypropeptide. So N-terminal propeptide. So N-terminal propeptide. So there is a peptide propeptide which has an N-terminal. So this can be detected, and type 1 procollagen. So PANP. So type 1 procollagen. So type 1 procollagen is also a marker which is released during post-translational cleavage of type 1 procollagen before its assembly into mature type 1 collagen fibrils. Okay, was released during post-translational cleavage of type 1 procollagen before. So released during post-translational cleavage of type 1 procollagen. So before, after the translation of cleavage of type 1 procollagen, but before the its message. So procollagen is translated and then it is assembled. So before the assembly and after the translation, so it is released. Therefore, yeah, one marker formation can include it as potential marker as well. So AST is predominantly found in the liver. So AST, so aspartate aminotransferase is predominantly found in the liver, muscles, and kidneys. AST is commonly used as a marker for hepatic injury and rhabdomyolysis and marker infection. So rhabdomy, muscle injury, muscle breakdown. Similarly, heart muscle breakdown, the myocardial infarction, they can be seen, AST can be measured here as well. Calcitonin is secreted by parafollicular C cells of the thyroid. So C cells of the thyroid produce calcitonin. Okay, and inhibit bone resorption of osteoclast. And the laboratory marker calcitonin is primarily used in diagnosis of medullary thyroid cancer. So calcitonin can be seen as a marker of medullary thyroid cancer. It doesn't mark osteoclastic activity. Similarly, acid phosphatase is a family of lysosomal enzymes present in a wide variety of cells, including osteoclasts. So acid phosphatase is a family of lysosomal enzymes present in a wide variety of cells, including osteoclast. The acid phosphatase in osteoclast is resistant to degradation by the tartrate. So acid phosphatase. So the acid phosphatase in osteoclast is resistant to degradation by tartrate. However, osteoblast do not express acid phosphatase. So osteoclast has acid phosphatase. So osteoclast. There is an osteoclast. So similar to alkaline phosphatase, acid phosphatase is present in osteoclast. So it cannot be degraded by tartrate. So osteoblasts do not have acid phosphatase. Osteoclastic activity leads to breakdown of fibrillar collagen. With osteoclastic so bone resorption leads to breakdown of fibrillar collagen, which is present in the bone, with release of biomarker like hydroxyproline and collagen tubercle. So osteoclastic markers are hydroxyproline, proline, collagen telepeptides, increase urine levels and osteopathy state of bone, increase bone resorption rather than formation. So hydroxyproline, when collagen degradated from proline, so because proline hydroxyproline is a marker or the raw material for the formation of collagen. So when broken down or resolved, then procollagen, that is hydroxyproline, can be formed, or collagen telepeptides can be seen, and terminal propeptide and type 1 procollagen as well as osteo-ALP are all markers of osteoblasts. All right, let's do it over here. Page number 50 will be soon beginning with rheumatoid arthritis.